Dear audience, let me introduce my PhD thesis, which is Infections in Fibrosing Interstitial Lung Diseases. My name is Zsombor Matic. I work in the Department of Pulmonology in the Semmelweis University, and I am an internal medicine specialist, and my second specialty will be infectology, because I'm interested in infectious diseases. That's why I have a vision that infectology will be an inseparable part of the evaluation of interstitial lung diseases. I have a team supervised by Veronika Müller, and together we have a mission to provide evidence-based data that draws attention to the importance of infectology. I have two projects ongoing. The first one was started in September of 2023, and it's called Comparing the Effect of Antifibrotic Treatment on the Incidence of Respiratory Tract Infection in Idiopathic Pulmonary Fibrosis. It's a systematic review and a network meta-analysis, and I already submitted it in July. The problem is that IPF is a rare but deadly disease with a median survival of 3 to 5 years. And the best treatment which can be given to the patients are antifibrotic drugs. These are standard of care now, but they can only slow down the progression of the disease. And we know that these antifibrotics reduce the investigator-reported acute exacerbations and mortality as well. And behind this high mortality, acute exacerbation of the disease is the main reason. Acute exacerbation is the #1 killer in idiopathic pulmonary fibrosis, and it can be triggered by many things, but infections are the most important because we can impact the numbers of infections, and reducing the occurrence of infections by any means is one of the most crucial things in preventing the evaluation of the pathogenesis of chronic lung diseases and preventing acute exacerbation of IPF as well. So we know that antifibrotics reduce the occurrence of acute exacerbations, but we don't know if any antifibrotics reduce the incidence of respiratory tract infections. So our aim is to investigate the effects of different antifibrotic treatments of IPF on the incidence of respiratory tract infections. Our clinical question: is there any antifibrotic drug associated with the reduced incidence of respiratory tract infections in IPF? To answer this question, we use a PECO framework, and our hypothesis is some antifibrotic treatments are associated with the reduced incidence of respiratory tract infections in IPF. We conducted a systematic search with this search key, and after the selection, 25 eligible full text remained. Here let me introduce my results. My outcome parameters are the incidence of respiratory tract infections, and again, we aim to do this research because reducing the incidence of respiratory tract infections can be the most important in preventing the #1 killer acute exacerbations. And the occurrence of respiratory tract infections can be very high in IPF. The range stands between 30 to 70% in a 1-year duration. So we included 25 randomized control trials, and we compared different drugs intended to treat IPF to placebo. And high heterogeneity can be seen in the pirfenidone group, where capacity 4 and 6 are outliers because they reported only serious adverse events and serious infections. So this is the main reason behind the high heterogeneity. And in the antibodies group and in the other drugs group, the high heterogeneity is caused by because we included drugs with different mechanism of actions. So based on our results and based on a 52-week treatment period, the currently used antifibrotic drugs, named as nintedanib and pirfenidone, were not associated with a lower risk of respiratory tract infections. To check which one is better for the patients, we conducted a network meta-analysis. We included 7 randomized control trials with more than 3,000 patients and almost 1,000 number of events. And based on our results, between the currently used antifibrotic drugs, there is no superiority on the impact of respiratory tract infections. For overall ranking, we used the random effect model to calculate a p-score, and based on our results, pirfenidone might be a little bit better for the patients than nintedanib, but again, our results are statistically not significant. For confidence rating, we used CINEMA, and due to high imprecision and incoherence and relatively high risk of bias and heterogeneity, we gave a very low confidence rating. We conducted subgroup analysis as well regarding dose dependency. We included the same randomized control trials with the same patients. And regarding dose dependency, we didn't observe any significant reduction associated with the currently used antifibrotic drugs on the impact on respiratory tract infections. Only in one single country study made in Japan, it was 1,800 milligrams per day of pirfenidone usage, and it was associated with a significant reduction on the respiratory tract infections. We conducted subgroup analysis as well by the localization of the infection. We differentiated upper and lower respiratory tract infections, and based on our results, there were no significant decrease on the impact of respiratory tract infections. Of course, we have some strengths and limitations. We pull data only from randomized control trials with high number of patients and high number of events. This is the first network meta-analysis, and it has a clinical significance, but we have some limitations, relatively high risk of bias, and the highest limitation of our study is the articles didn't report any microbiological results or diagnostic methodology behind the testing. So our conclusion is that the currently used antifibrotics are safe and do not change the incidence of respiratory tract infections without any difference between the two drugs. Our implication for practice is that the currently used antifibrotic drugs can safely be utilized without risking increased incidence of respiratory tract infections. And our implication for research is further randomized control trials with add-on therapies and real-world studies with respiratory tract infection incidence as a main outcome needed. So my first project is in an advanced stage. I have finished writing my manuscript, and I already submitted it to a D1 journal called eClinical Medicine in July. My second topic, called Comparing the Effect of Different Immunosuppressive Treatments on the Incidence of Infections in Scleroderma-Related Interstitial Lung Disease, is a systematic review, and hopefully it will be a network meta-analysis as well, and I plan to submit it until November. The problem is that ILD is one of the major forms of lung involvement in patients with systemic sclerosis limiting survival. The prevalence of ILD approaches 50% of patients with diffuse cutaneous systemic sclerosis. So we know that ILD plays an essential role in contributing to the death of patients, and we know that the occurrence of ILDs and the progression of ILDs can be decreased if we treat the patients with immunosuppressants. But these are risky treatments because they also increase the risk for infections, which also leads to death. So our clinical question, is there any immunosuppressive therapy associated with a reduced incidence of infections compared to other immunosuppressants in systemic sclerosis associated ILD? To answer this question, we use the PFO framework, and our hypothesis is some immunosuppressive treatment are associated with the reduced incidence of infections in scleroderma-associated interstitial lung disease. And it is very important because if there is an association, we can rank the available immunosuppressive treatments based on their effect on treatable traits such as infections. So we conducted a systematic search with this search key, and my second project is in this phase. I started to register my Prospero, draft my protocol, and I'm waiting for the approval for them. So to summarize, I have two projects ongoing, and I plan to submit them until November. And here I want to thank you for your attention, and want to open the discussion part with the words of Albert Einstein. The important thing is not to stop questioning. Thank you very much.
Thank you, John Bor. Very nice talk. And before I ask the panel for questions, may I encourage the audience to formulate questions and challenge the speaker as hard as you can, okay? And with this, I hand over the microphone to whoever wants to ask the first question. Dear professors, okay. Oh.
Just, what is your presumption regarding your second project? what are you expecting to find? Which would be theoretically the best immunosuppressive or not as bad immunosuppressive? What are you expecting?
So nowadays, the first choices are mycophenolate mofetil and cyclophosphamide. But there are a few randomized controlled trials. These were pilot studies which tested rituximab as well. And as I checked, I have already the preliminary data extraction sheet. So I have a few data. So I think rituximab might be the best for the infections.
So this is your presumption. Okay,
Yeah.
Thank you very much.
While you're thinking, there was just one thing that caught my eye, that you made a subgroup analysis in your first project between upper respiratory tract and lower respiratory tract infection. I can see the relevance. What is your interpretation of so if, let's say, you found something, the difference, how would you interpret that? So what is the clinical importance if there is a difference between drugs, for example, in upper airway tract infection?
Okay. So these drugs I included, like pirfenidone and nintedanib, they were tested in many randomized controlled trials, so they prove that they decrease the mortality rate. So it's proven. But since the disease is uncurable, we want to target treatable traits like infections. And we differentiated upper respiratory tract infections and lower respiratory tract infections. Upper respiratory tract infections, because upper respiratory tract infections can also trigger acute exacerbation of the disease. And lower respiratory tract infections, because maybe these antifibrotic drugs, as they reduce the progression of the disease, maybe they indirectly will reduce the numbers of infections in lower respiratory tract infections as well. So we differentiated because upper respiratory tract infection, because we want to prevent the exacerbation, and lower respiratory tract infection on one hand, because we want to prevent the acute exacerbation, and we want to indirectly check if lower respiratory tract infections rates are decreased because of the progression, the reduction of the progression of the disease. Yeah.